So I'll be focusing on cardiovascular and pulmonary considerations, and just to follow up on Waleed's introduction, as you can imagine, a lot of the evidence in these two organ systems was indirect. There was no real direct evidence in the setting of liver failure, so you'll see a lot of recommendations that are predominantly conditional. So with that preface, just a moment to acknowledge all the authors in this guideline, the tireless efforts and passion and dedication. So just a word of appreciation for this great group that I had a chance to work with. So cardiovascular. The first question was choice of initial resuscitation fluid. And so a couple of recommendations as far as pertinent negatives. We recommend against using hydroxyethyl starch for initial fluid resuscitation in patients with ALF and ACLF. This was a strong recommendation with moderate quality evidence. And number two, we suggest against using gelatin solutions for initial fluid resuscitation in patients with ALF and ACLF. And this was a conditional recommendation with low quality evidence. And just the rationale for these two above statements, and by the way, all the references are in the guidelines. Meta-analysis of trials in critically ill patients suggests no benefit, as you know, of hydroxyethyl starch or gelatin solutions over crystalloids. And then specifically with regard to liver disease or liver failure, there's some suggestion, in general critical care as well, of increased risk related to hydroxyethyl starch compared to crystalloids, including exacerbation of coagulopathy in liver failure. Question number two, and this is an interesting question as we debated this, albumin as resuscitation fluid. So the recommendation we came up with is we suggest using albumin for resuscitation of patients with ALF or ACLF over other fluids, especially when serum albumin is low, defined as less than 3 milligrams per deciliter. And this was a conditional recommendation with low quality evidence. But just to go over the rationale for this recommendation, as you may be aware, in liver failure patients, there may be both a quantitative and a qualitative dysfunction in the albumin molecule in these patients. And so in addition to volume expansion, in this set of patients, albumin administration may improve hemodynamics using both via antioxidant and immunomodulatory pathways in addition to just being a volume expander. And the third sort of interesting piece of evidence is that when you look at meta-analysis directed to this question, there's benefit of albumin in preventing post-paracentesis circulatory dysfunction with that specific odds ratio and decreasing mortality. So as we thought about this evidence, extrapolating it to shock, we felt that there is a reasonable support for thinking about albumin earlier than later as far as using it as a resuscitation fluid in this patient population. All right, moving on to blood pressure targets. Very similar to septic shock. We suggest targeting a mean arterial pressure of 65 millimeters of mercury in patients with ALF and ACLF with concomitant assessment of perfusion. This was a conditional recommendation with moderate quality evidence. But just with a caveat or with a remark that some patients will have adequate perfusion at a lower MAP. As you know, some of these patients with their normal MAP may be 60, and others will have an improvement of perfusion at higher mean arterial pressures. Another comment here, and this will be addressed more when we publish as Part B of these guidelines related to neurologic issues. In the setting of severe ALF and possible risk of intracranial hypertension, there may be a benefit of targeting a higher MAP to optimize cerebral perfusion pressure. And just as far as the rationale, again, we're extrapolating data, indirect evidence from the surviving sepsis guidelines that recommended a target MAP of 65, and that we use the rationale that the form of shock in these patients, which is distributive shock, is similar to what we see in septic shock. So that is indirect evidence supporting this recommendation. Let's move on to hemodynamic monitoring. So recommendation 1 is we suggest placing an arterial catheter for blood pressure monitoring in patients with ACLF or ALF and shock. This is conditional, recommendation with low quality evidence. And the rationale for this is that compared to non-invasive cuff measurements, A-line readings provide a more accurate and continuous assessment of arterial blood pressure in the setting of shock in this patient population. Recommendation 2, we suggest using invasive hemodynamic monitoring to guide therapy for shock in patients with ALF or ACLF, conditional, low-quality evidence. Just a remark that there's an evolving role of echocardiography in hemodynamic monitoring and assessment. And the rationale for this, as you can imagine that really sick cirrhotic who has massive anasarca, that non-invasive assessment of intravascular volume and cardiac output is very challenging in these patients. Hence the support for or recommending invasive hemodynamic monitoring. Moving on to choice of vasopressor agents. Recommendation 1, we recommend using norepinephrine as the first-line vasopressor agent of choice in patients with ALF or ACLF who have shock that's refractory to fluid resuscitation. We made this a strong recommendation with moderate quality evidence. And again, this is based on indirect evidence that from data in septic shock and given the similarity of the shock, this distributed shock in liver failure. Recommendation 2, we suggest adding low-dose vasopressin for shock that's refractory to norepinephrine in patients with ALF or ACLF. Conditional recommendation, low-quality evidence. And again, this is just an extrapolation of data that we have gleaned or learned from septic shock data that with a mortality benefit. So that's cardiovascular. Let's switch gears and move on to pulmonary considerations. So first question is tidal volumes in mechanical ventilation. And again, very similar to what we do in the surviving sepsis guidelines, which is to suggest using a low tidal volume strategy over a high tidal volume strategy in patients with ALF or ACLF who have ARDS. And again, this is a conditional recommendation, low quality evidence. And again, this is all based on indirect evidence from general critical care that demonstrates a benefit, as you know, of a low tidal volume strategy in ARDS with respect to mortality. And meta-analyses of low and versus non-volume targeted tidal volume strategies have demonstrated reduction in mortality in the low tidal volume group. What about use of PEEP, positive end-expiratory pressure? The recommendation is we suggest against using high PEEP over low PEEP in patients with ALF or ALF or ACLF and ARDS. This is a conditional recommendation, low quality evidence. And just a remark, very similar to what we do in general critical care, a high PEEP strategy may be considered in moderate to severe ARDS after balancing the potential benefit to risk of increasing ICP and reducing venous return, which may be specific issues of concern in this patient population. Again, the rationale again is indirect. Evidence from general critical care does not demonstrate a mortality benefit of a high PEEP strategy in ARDS, except possibly in moderate to severe. And as I'd mentioned, things to be cognizant of in the patient with ALF is elevated ICP, and especially in the patient with ACLF, the effects of high PEEP on venous return. Moving on to use of pulmonary arterial hypertension therapy in portopulmonary hypertension. The recommendation here is we suggest treating portopulmonary hypertension with agents approved for the treatment of pulmonary arterial hypertension in patients with a mean pulmonary arterial pressure greater than 35 millimeters of mercury. This was conditional with very low quality evidence. And again, the rationale here is that for those of you who take care of these patients, current POPH treatment strategies are based on extrapolation from the broader literature that addresses treatment of general pulmonary arterial hypertension. And there are some uncontrolled small observational studies suggesting that these general pH-based therapies, including IV Flolan, for example, sildenafil, and the endothelin receptor antagonists, could be beneficial in portopulmonary hypertension as well. What about hypoxemia in patients with hepatopulmonary syndrome? The recommendation here was we recommend supportive care with supplemental oxygen, as you do, in the treatment of HPS, pending possible liver transplantation. This is a best practice statement. And as you may be aware, there's no effective pharmacological therapies apart from oxygen, with liver transplantation being the only proven therapy that can reverse hepatopulmonary syndrome. The next question in pulmonary was tube thoracostomy in hepatic autothorax. This is another sort of question that created some debate, but this is the recommendation we came up with. We recommend placing chest tubes with an attempt to pleurodesis for hepatic autothorax in patients whom TIPS is not an option or as a palliative intent, and this is a best practice statement. The rationale here, and this is actually data that's coming straight from some liver literature, is that in a systematic review of patients with hydrothorax, hepatic autothorax, undergoing pleurodesis, complete response was reported in 72% of patients. In addition, tube thoracostomy has been used as a bridge to transplant in a small series of patients. A caveat to this strategy, just to make you aware, there is a meta-analysis showing there's increased risk of infection with tube thoracostomy in hepatic autothorax. So that is a potential point of concern with regard to these patients. Finally, the last question in the pulmonary section, use of high-flow nasal cannula and non-invasive ventilation. The recommendation here is we suggest using high-flow nasal cannula over non-invasive ventilation in hypoxic critically ill patients with ALF or ACLF. This is a conditional recommendation, low-quality evidence. And again, this is an extrapolation of evidence from general critical care. The remark here is that in patients with hypercarbia and purely ventilatory failure, it may be more appropriate to use NIPPV over high-flow nasal cannula. The rationale, again, just to state the evidence or the indirect evidence, in general critical care, there's demonstrated no differences in mortality or intubation rates in hypoxemic critically ill patients when you compare high-flow nasal cannula versus NIPPV. And as you're aware, high-flow nasal cannula offers greater patient comfort. And again, from a liver patient or ALF or ACLF standpoint, high-flow nasal cannula may have lesser impact on ICP and venous return due to a lower effective PEEP compared to NIPPV. I think that concludes the cardiovascular and pulmonary. Thank you for your attention. I'll turn it over to Dean Carvelis. Yeah.
Hi, thanks, Ram. And our final speaker is Dean Carvelis. Dean is an associate professor of gastroenterology, hepatology, and critical care at the University of Alberta, and again, one of my other co-chairs. Welcome.
Thank you very much, Ram and Rahul and Waleed. This next section, we're going to cover the recommendations for the endocrine, hematology, and renal subgroups. And as mentioned before, there are still other groups that will be reviewed and published with the second part of the guideline. So just once again to acknowledge all the contributors to this vast amount of work. So we'll start with renal considerations, and just want to highlight that there are some subtle differences between acute liver failure, which is a necroinflammatory process, and acute-on-chronic liver failure, which is our cirrhotic fibrotic portal hypertensive patient. And you may see a couple of subtle references that's specifically talking about ALF versus ACLF. So the first recommendation is the timing of renal replacement therapy in patients with AKI this is acute liver failure only. And this was a suggestion. We suggest using renal replacement therapy early in patients with acute liver failure and acute kidney injury. This was a conditional recommendation with a very low quality of evidence. The idea here is that continuous renal replacement therapy prior to the development of AKI has been associated with improved outcomes. And one of the potential theories for this is it might mitigate intracranial hypertension and the formation of cerebral edema. Just to mention, we know that there's a lot of uncertainty in the general critical care literature in the timing of AKI, and as such, there's insufficient evidence to issue a recommendation for the ACLF population. Secondly, vasopressors in hepatorenal syndrome. This is a bit of overlap with the previous group. Recommendation, we recommend using vasopressors over not using vasopressors in critically ill patients with acute-on-chronic liver failure or cirrhosis who have developed hepatorenal syndrome. This was a strong recommendation with moderate quality evidence. One of the remarks is that vasopressors could be any of terlipressin, norepinephrine, midodrine, or octreotide. The rationale has been based on a couple of different systematic reviews, 9 randomized clinical trials comparing terlipressin to placebo in 534 patients with HRS, which showed 92 fewer deaths per 1,000 HRS patients receiving terlipressin, where there's the most robust data. As you're still aware, we don't have terlipressin in North America, but we hope it's going to be licensed in the next year. What about intraoperative renal replacement therapy during liver transplantation? There's insufficient evidence to issue a recommendation. The remark that patients with ongoing emergent indications for renal replacement therapy, such as hyperkalemia or severe acid-based abnormalities, should not have their renal replacement therapy discontinued prior to transplant. This is essentially based on pooled data, low-quality evidence, and one recent prospective randomized pilot study that showed a high crossover between control and intraoperative CRRT that did not show any benefit in either renal or survival outcomes. So what about transjugular intrahepatic portosystemic shunt, or TIPS, for the prevention of hepatorenal syndrome? The recommendation is that there is insufficient evidence to issue a recommendation. Rationale is that the creation of TIPS is an establishment treatment option for major complications of portal hypertension, such as ascites and variceal bleeding. We looked at a meta-analysis of 6 randomized trials, which compared TIPS versus paracentesis and refractory ascites. There was less AKI in the TIPS group, but there's an increased rate of hepatic encephalopathy. And unfortunately, these randomized controlled trials didn't focus on critically ill patients, which quite often are excluded from many of these trials. So next we have the hematologic considerations in both ALF and acute-on-chronic liver failure. So assessment of bleeding or thrombosis risk. Recommendation: when available, we suggest using viscoelastic testing such as TEG and ROTEM over measuring INR, platelet count, and fibrinogen in critically ill patients with acute or acute-on-chronic liver failure. This is a conditional recommendation with low-quality evidence. We know that traditional coagulation tests such as INR do not necessarily represent the whole hemostatic profile in these patients, and that viscoelastic testing, including TEG and ROTEM, allow for real-time assessment of global and functional evaluation of altered pro- and anticoagulant pathways. Hemoglobin targets. The recommendation was we suggest a transfusion threshold of greater than 7 milligrams per deciliter over other thresholds for critically ill patients with ALF and ACLF. This was a conditional recommendation with low-quality evidence. This was based on one single large randomized trial that included both cirrhotic and non-cirrhotic patients, where a restrictive transfusion strategy compared to a liberal strategy conferred significant fewer transfusion reactions and adverse events. As mentioned, this study had non-cirrhotic patients as well, but when looking only at the cirrhotic subgroups, the restrictive strategy was not significantly different to a liberal strategy for death at 6 weeks, but there may have been actually a potential mortality benefit in Child-Pugh A and B cirrhotic patients. So venous thromboembolism prophylaxis, we suggest using low molecular weight heparin over pneumatic compression stockings for DVT prophylaxis in hospitalized patients. This is only in acute-on-chronic liver failure, and this is a conditional recommendation with low-quality evidence. The remark is that there's insufficient evidence to allow a recommendation for patients with ALF. The rationale is that cirrhotic ACLF patients are at increasing risk of developing venous thrombosis and this was largely based on one single-centered study that it was borrowed literature. It was outpatient cirrhotic patients where they were stratified to low molecular weight heparin versus control. And this study found that there was decreasing rates of portal vein thrombosis and rates of hepatic decompensation with no difference in bleeding. Assessment for the risk of bleeding with invasive procedures. This recommendation, we recommended viscoelastic testing over measuring INR, platelet, fibrinogen in critically ill patients with ALF or ACLF undergoing procedures. This was a strong recommendation with moderate quality evidence. We know that bleeding risks in ACLF patients with minimally invasive procedures such as paracentesis, thoracentesis, and liver biopsy kind of ranges between about 0 and 2%, and that bleeding does not correlate with INR. There was a single open label RCT that looked at patients that were they got standard of care blood testing versus TEG and ROTEM, and the patients in the TEG arm had significantly fewer units of blood product transfusion with no difference in bleeding complications or 90-day mortality. Finally, endocrine considerations. So target glucose control. We recommend targeting a serum blood glucose of between 110 and 180 milligrams per deciliter in patients with acute or acute-on-chronic liver failure. Strong recommendation, moderate quality of evidence. Rationale is that endocrine abnormalities we're aware are common in patients with liver disease and often necessitate pharmacotherapeutic intervention to prevent adverse events because of adverse changes to glucose metabolism. Management should incorporate the prevention of both hyper and hypoglycemia to promote the shortest safe hospital stay and provide an effective transition out of hospital that prevents acute complications. And this is based on a retrospective study. Role of stress dose glucocorticoids, which we know there's a lot of controversy in equipoise in the general septic shock literature. The recommendation was we suggest using stress dose glucocorticoids in the treatment of septic shock in patients with ALF or ACLF. This was a conditional recommendation only with low quality evidence. The remark is that stress dose glucocorticoids should be used if adequate fluid resuscitation and vasopressor agents are unable to restore hemodynamic instability. This is based on the fact that relative adrenal insufficiency is actually common in acutely ill patients with cirrhosis, especially those with septic shock. This is consistent with, as mentioned before, with guidelines in both cirrhotic and non-cirrhotic patients with septic shock. So dietary protein load, this comes up from time to time because we know that protein load to the gut can feed ammonia production, which patients with ALF and ACLF may have challenges with metabolizing. The recommendation was we suggest against the use of a low-protein diet in patients with ALF or ACLF, but rather targeting protein goals comparable to critically ill patients without liver failure. So this is 1.2 to 2 grams per kilo ideal body weight. Conditional recommendation with very low quality of evidence. Really, the rationale here was that we know that in patients with cirrhosis often have sarcopenia and are at risk with muscle wasting, and further protein restricting them will actually deleteriously impact their outcome. There was a RCT of 121 cirrhotic patients randomized to receiving a nutritional therapy program with 1 to 1.5 grams per kilo ideal body weight, and nutrition and education versus no nutrition therapy at all. In the intervention group received more protein, and yet were less likely to advance to overt hepatic encephalopathy, one of their endpoints of complications of cirrhosis. So route and timing of feeding. The recommendation was we suggest enteral nutrition over parenteral nutrition in critically ill hospitalized patients with ALF or ACLF without contraindication to enteral feeding. This is once again a conditional recommendation with low quality evidence. The rationale is that the preferential use of enteral nutrition unfortunately has not been studied specifically in patients with ALF or ACLF. This is based on previous borrowed literature from meta-analysis representing heterogeneous groups of critically ill patients that favored enteral nutrition if we're available to use the gut. And the rationale for this is also to prevent bacterial translocation through trophic feeding of enterocytes. Screening for drug-induced causes of liver failure. We recommend screening patients with ALF and ACLF for drug-induced liver injury. Drugs that are proven or highly suspected to be the cause of ALF or ACLF should be discontinued. This is a best practice statement based essentially on the rationale that drug-induced liver injury accounts for more than 50% of acute liver failure in the US. And while DILI is sometimes a diagnosis of exclusion, the use of a validated score such as the RUCAM score can increase certainty. There is some data on which has been collected by the Dillon Network, which you can find at livertox.gov. And if there are drugs with proven or highly suspected of being related to ALF in particular, should be immediately discontinued. Where available, an antidote should be administered accompanied by supportive care. Dose adjustments of medications. In patients with ALF, ACLF, we recommend adjusting the doses of medications that undergo hepatic metabolism based on the patient's residual hepatic function and using the best available literature. When available, a clinical pharmacist should be consulted. This is essentially a best practice statement. We're aware that both in ALF and ACLF, you get alterations in the hepatic extraction ratio, biliary excretion, volume of distribution, and protein binding. So obviously, other confounding factors that may affect this include acute kidney injury, as well as the use of renal replacement therapy, where we do have pharmacokinetic data, but for other extracorporeal circuits, the data is a little more scant. Thank you very much.